Hello, welcome to the second lecture in the series of abdominal sonography. In this series we're going to cover not only abdominal sonography, we're also going to cover obstetrics, gynecology in a few small parts. And so for today we're going to go over liver anatomy, some pathologies of the liver, as well as some methods for scanning the liver. So we shall begin by going over a few key terms. Now, the liver is a vital organ, and therefore much attention should be paid to the significance of comprehending its function, as well as the various pathologic changes that can distort its sonographic appearance. And so that is why I have quite an extensive list of key terms. So first and foremost, we're going to go over this first line here. So amoebic hepatic abscesses. These are abscesses that develop from a parasite, and the parasite is the amoeba, the unicellular organism, and it ends up invading the colon where it grows. Then it goes on to invade the liver via the portal vein. Anastomosis, this is a surgical connection between two structures. Arteriovenous fistula, it's an abnormal passageway between an artery and a vein. Autoimmune disorders, these are disorders in which the body's immune system attacks and destroys healthy tissue. Autosomal dominant polycystic disease, and we had looked at this in the last lecture, albeit briefly. And this is an inherited disease that results in the development of renal, liver, and pancreatic cysts later in life. So we talked about the autosomal dominant variant of this. Shows up much later in life, usually with adults, whereas the autosomal recessive variant appears in infancy or in fetal life. The Bay Area, this is a region of the liver not covered by the peritoneum. We said the liver is covered anteriorly by the peritoneum, and it has a Bay Area posteriorly, which is free. Beckwith-Wideman syndrome, this is a growth disorder synonymous with enlargement of several organs, including the skull, tongue, and liver. Budd-Chiari syndrome, this is a syndrome described as the occlusion of the hepatic veins, and there's possible coexisting occlusion of the inferior vena cava. Caput medusa, this is a recognizable dilation of the superficial veins of the abdomen. Caput medusa, we know Medusa is the Greek mythological creature that has snakes for hair. And when we say caput medusa, we are referring to Medusa's head. Cavernous hemangioma, it's the most common benign liver tumor. Cholangitis, inflammation of the bile ducts. Chirosis, a condition defined as hepatocyte death, where there's fibrosis and necrosis of the liver, and subsequent development of regenerating nodules. Cystic fibrosis, this is a genetic disorder linked with the development of scar tissue, and the scar tissue accumulates within the lungs, the liver, pancreas, kidney, and/or intestines. Diaphragmatic slip, this is a pseudomass of the liver that can result from hypertrophied diaphragmatic muscle bundles. Dysentery is an infection of the bowel, which leads to diarrhea, and dysentery may have mucus or blood in the digestion. An echinococcal cyst is similar to a hydatid cyst, and an echinococcal cyst is a cyst that is caused by the Echinococcus granulosus parasite, and it is the parasite responsible for the development of hydatid liver cysts. The Epstein-Barr virus, a virus that is responsible for mononucleosis and other potential complications. Fatty liver, this is a reversible disease characterized by deposits of fat within hepatocytes, and we refer to it as hepatic steatosis. Fibrosis, this is the formation of excessive fibrous tissue or the development of scar tissue within an organ. So, fatty liver can present as focal fatty infiltration or focal fatty sparing. And focal fatty infiltration manifests as a fatty liver disease in which fat deposits are localized, which is opposed to focal fatty sparing, which is a manifestation of fatty liver disease in which an area of the liver is spared from fatty infiltration. Focal nodular hyperplasia, this is a benign liver mass composed of a combination of hepatocytes and fibrous tissue, and it typically contains a central scar. The gastroesophageal junction, this is junction between the stomach and the esophagus. Glisson's capsule, this is the thin fibrous capsule casing of the liver. Hematemesis, this is vomiting blood, and not to be confused with hematoma. Hematoma is a localized collection of blood. Also not to be confused with hemochromatosis. And hemochromatosis is an inherited disease characterized by disproportionate absorption of dietary iron. Hermopoiesis is a formation and the development of blood vessels. Hepatic candidiasis is a hepatic mass that results from the spread of fungus into the liver. Hepatic encephalopathy, this is a condition in which a patient becomes confused or suffers from intermittent loss of consciousness secondary to the overexposure of the brain to toxic chemicals that the liver would otherwise remove from the body. Hepatic steatosis, which is similar to fatty liver, and we were saying that in cases of fatty liver, we can refer to fatty liver disease as hepatic steatosis. Hepatitis, this inflammation of the liver. Hepatocellular adenoma, this is a benign liver mass often associated with the use of oral contraceptives. Hepatocellular carcinoma, this is a primary form of liver cancer. Hepatofugal, in conjunction with hepatopetal, are two directions of blood flow. Hepatopetal is blood flow towards the liver. Hepatofugal is blood flow away from the liver. A hepatoma is a malignant tumor associated with a hepatocellular carcinoma. Hepatomegaly is enlargement of the liver, and a hepatosplenomegaly is a combined enlargement of the spleen and the liver. A hydatid liver cyst is a liver cyst that develops from a tapeworm. And we also refer to hydatid liver cyst as echinococcal cysts because they originate from the parasite Echinococcus granulosum or granulosus. In this case, an echinococcal cyst can also be referred to as a hydatid liver cyst. And this parasite, this tapeworm, lives in dog feces. Hyperlipidemia, these are abnormal high levels of fat within the blood. Hypovolemia, this is decreased blood volume. Idiopathic, there is no recognizable cause from an unknown origin. Immunocompromised, a patient with a weakened immune system. Jaundice, this is the yellowing discoloration of skin. the sclera and mucous membranes found with biliary obstruction. Kernicterus, this is brain damage from bilirubin exposure in newborns with jaundice. Kupffer cells are specialized macrophages within the liver that engulf pathogens and damaged cells. Leukocytosis, we saw this in a synopsis of key terms. This is an elevated white blood cell count. Lipoma is a benign fatty tumor. The liver hilum is an area of the liver where the common bile duct exits the liver, and the portal vein and the hepatic artery enter the liver. We also refer to this as the porta hepatis. Low resistance flow is a flow pattern that characteristically has antegrade flow throughout the cardiac cycle. Malaise is a general feeling of uneasiness. Malignant degeneration is a deterioration of a benign mass into a malignancy, and we will discuss some of these changes that turn benign masses into malignant masses. And one of the changes is losing around structure to become more spiculated. Mass effect, this is a displacement or alteration of normal anatomy, and it is often located adjacent to a tumor. Monophasic, this is vascular flow yielding a single phase. Necrosis, this is death of tissue. Periportal cuffing is an increase in the echogenicity of the portal triads, as seen in hepatitis and other conditions. And so we talked about the liver hilum, or the porta hepatis, and this area of the liver where the hepatic artery enters and the hepatic duct exits. Portal hypertension, this is elevation of blood pressure within the portal venous system. The portal triads, this is an assembly of a small branch of the portal vein, the bile duct, and the hepatic artery, and these surround each liver lobule. Partial vein thrombosis, this is the development of a clot within the portal vein. Pseudochirosis, this is a nodular appearance of the liver caused by multiple metastatic tumors. A pseudomass is a false mass. A pyogenic liver abscess is an abscess that can result from the spread of infection from inflammatory conditions, such as appendicitis. The quadrate lobe is a medial segment of the left lobe. Recanalization is the reopening of canals or pathways. Rhyidal lobe is a tongue-like extension of the right hepatic lobe. Sequelae, this is an illness resulting from another illness, trauma or injury, or we can say resulting from the progression of disease. Serpiginous, this is twisted or snake-like. Situs inversus, a condition in which organs of the abdomen and chest are on opposite sides of the body. So an example of this would be the liver is within the left upper quadrant instead of the right upper quadrant. We had already looked at splenomegaly with hepatosplenomegaly, but splenomegaly is the enlargement of the spleen. The starry sky sign is a sonographic sign associated with the appearance of periportal cuffing. And with this periportal cuffing, there's increased echogenicity of the walls of the portal triads. And this presents as a starry sky sign. Steatohepatis is a type of fatty liver disease that causes inflammation of the liver. Total parental hyperalimentation is a procedure in which an individual receives vitamins and nutrients through a vein, and oftentimes they use the subclavian vein. Transjugular intrahepatic portosystemic shunt. This is a therapy for portal hypertension that involves the placement of a stent between the portal veins and the hepatic veins to reduce portal systemic pressure. Triphasic, this is vascular flow yielding three phases. Von Gerke disease is a condition in which the body does not have the ability to break down glycogen. We refer to von Gerke disease as glycogen storage disease type 1. Von Hippel-Lindau disease, we looked at this also in the lecture prior, is an inherited disease that includes the development of cysts within the liver, pancreas, and other organs. Wilson's disease is a congenital disorder that causes the body to accumulate excess copper. So moving on, we move on to liver anatomy. So first and foremost, the liver is the largest abdominal organ in the body, and the majority of its bulk is the right lobe. And the liver is located in the right upper quadrant, but the left lobe can extend into the epigastrium. So that is to say, a majority of the liver is located in the right upper quadrant of the abdomen. But in certain cases, the left liver lobe can extend, or even generally, into the epigastrium. And in some cases, in some humans, the left lobe can extend past the midline into the left hypochondrium. The liver is considered an intraperitoneal organ, with only a small portion of it left uncovered, and this is the bare area, the area of the falciform ligament. It also houses the gallbladder fossa, the porta hepatis, and the area adjacent to the inferior vena cava. The liver is covered by Glisson's capsule, which is a thin fibrous casing, and it is composed of 4 hepatic lobes, a right-left, quadrate-caudate, and each hepatic lobe can be further divided into thousands of liver lobules. And these lobules contain hepatocytes, biliary epithelial cells, and Kupffer cells. And each of these lobules is surrounded by a portal triad. And the portal triad is composed of a branch of the portal vein, the bile duct, and the hepatic artery. Now we are going to talk about the segmentation of the liver later on in this presentation. So early on I had said that the liver is very important in its function in the human body, and there are a lot of vital functions of the liver. And there's a very important enzyme in the liver known as cytochrome P450, but I won't go into that in this presentation. So vital functions of the liver include carbohydrate metabolism, fat metabolism, amino acid metabolism, removal of waste products. The liver is important in the metabolism of ethanol, vitamin and mineral storage, drug inactivation, synthesis and secretion of bile. It is a blood reservoir, lymph production, and detoxification. So next we move on to the segmentation of the liver. So we use the Coinard system, and we use it to separate the liver into 8 surgical segments. This is important in case the liver is going to be operated on. It is very easy to standardize location of hepatic masses, and once they're standardized, surgeons can then go on and section these out. So the Coinard system is used to separate the liver into 8 surgical segments. But fundamentally, the liver can be divided into 4 primary hepatic lobes. We have a right lobe, a left lobe, a caudate lobe and a quadrate lobe. The quadrate lobe is located between the gallbladder fossa and the round ligament, near the bare area or area nuda. The right hepatic lobe is the largest lobe, and it makes up most of the right upper quadrant. And the right lobe can be divided into anterior and posterior segments, and it can be divided into segments by the right hepatic vein. And the right hepatic vein lies within the right intersegmental fissure. The right lobe can be separated from the left lobe by the middle hepatic vein, which lies within the main lobar fissure. And the right and left lobes also separated by the gallbladder fossa. The left lobe is much smaller than the right lobe, and it is located within the epigastrium and may extend to the left hypochondrium. And the left lobe may be divided into medial and lateral segments by the left hepatic vein within the left intersegmental fissure. Right, so let's expand on this, right? So we have these three finger-like projections, which are the branches of the hepatic vein. We have the right, the middle, and the left. The middle hepatic vein runs through the main lobar fissure, and it primarily separates the right and left liver lobes. Now the left and right liver lobes are further separated into the left medial and lateral segments and the right anterior and posterior segments by the left and right hepatic veins respectively, which are running through the left intersegmental fissure and the right intersegmental fissure. So we can also separate liver segments by the ligamentum teres and the falciform ligament. So the caudate lobe is the smallest hepatic lobe, and it is located within the epigastrium as well. And it is bound anteriorly by the ligamentum venosum, which is a remnant of the ductus venosus, and posteriorly by the IVC. So thus we can separate the caudate lobe from the left lobe by the ligamentum venosum. So we come to the portal vein, and the portal vein is the main vein that enters the liver at the porta hepatis. The portal vein is created by a union of the superior mesenteric vein and the splenic vein. A merger of these two vessels meets the inferior mesenteric vein, and this typically takes place posterior to the neck of the pancreas and anterior to the IVC, and it is an area we refer to as the portal confluence or the portal splenic confluence. So that is to say, three veins unite at the portal confluence to create the main portal vein. And these vessels are the superior and inferior mesenteric vein, as well as the splenic vein. The portal vein provides the liver with approximately 75% of its total blood supply, and the blood within the portal vein is only partially oxygenated. The remainder of hepatic perfusion occurs via the hepatic artery. As the main portal vein enters the liver, it splits into what we call the right and left portal veins. And so this is very important. At the porta hepatis, the portal vein enters and splits, going once to the right and then again to the left. And the right portal vein is separated in an anterior and posterior division, much like the right lobe, and the left portal vein is separated into a medial and lateral division. The diameter of the main portal vein can vary with respiration, although typically it measures less than 13 millimeters in the AP dimension. So if we want to get the AP dimension, we'd have to scan transversely. Enlargement of the portal vein is often indicative of portal hypertension. The normal portal vein decreases in size as it approaches the diaphragm, and these portal veins are also considered intrasegmental because they course within the segments of the liver. On a sonogram, the walls of these portal veins appear much brighter than those of the hepatic veins. And one of the explanations for this is an increase in the amount of collagen within their walls. And normal flow within the portal veins should be hepatopetal and monophasic. That is to say, blood is flowing into the liver and blood is monophasic. It has one peak. We can have some variation noted with respiratory changes. And you should keep in mind that scanning after a meal will often demonstrate an increase in portal venous flow. So how do we test for the normal function of the liver? Well, there's a number of liver function tests that we can perform. We can check for albumin, and a decrease in albumin will indicate some cirrhosis or some chronic liver disease. Alkaline phosphatase, its increase would indicate cirrhosis or some extrahepatic biliary obstruction, some gallstones, hepatitis, metastatic liver disease, or pancreatic carcinoma. Alanine transferase, if it increases, can indicate biliary tract obstruction, hepatitis, or hepatocellular disease or obstructive jaundice. AST increase would indicate cirrhosis, fatty liver, hepatitis, metastatic liver disease. Gamma glutamyl transferase, if it increases, would indicate diffuse liver disease or post-hepatic obstruction. LDH increases would indicate cirrhosis, hepatitis, obstructive jaundice. Serum bilirubin increases would, well, depends. If bilirubin is unconjugated, we are looking at acute hepatocellular disease. If it is conjugated, then we're looking at biliary tract obstruction. If there's an increase in total bilirubin, we're looking at cirrhosis, hepatitis, and other liver cell disease. So our PTFP and prolonged prothrombin time probably indicates metastasis of the liver and hepatitis. If it is shortened, it can indicate extrahepatic duct obstruction, and AFP increases can lead to hepatocellular carcinoma or a hepatoblastoma. So we come to a very important anatomical landmark, I would say, but maybe not necessarily a landmark, but the hepatic veins. And I would like to say there's a specific way the portal veins and hepatic veins unite to create for us our choanide classification. And that is to say, after the hepatic veins have divided the liver into four let me say four quadrants, let me say that is much better, four quadrants, then the left and right portal vein can be seen forming an axis through which the liver can be sectioned axially, and this will create your anterior posterior segments for the right lobe and your superior inferior segments of the left lobe. So the hepatic veins, most people have three, are right, middle, and left, and they're used readily to distinguish hepatic segments. And unlike the portal veins that decrease in size as they approach the diaphragm, the hepatic veins increase in size. Hepatic veins have a triphasic blood flow as opposed to the monophasic blood flow of the portal veins, and they're associated with the right atrium and atrial contraction through the inferior vena cava. So enlargement of the hepatic veins and the IVC is seen with right-sided heart failure, and occlusion or narrowing of the hepatic veins is seen with Budd-Chiari syndrome. So next we can move on to the porta hepatis and useful landmarks. So the right hepatic vein and the right intersegmental fissure separate the interior segment of the right lobe from the posterior segment of the right lobe. The middle hepatic vein running through the main lobar fissure, as well as the gallbladder fossa. No, it is not running through a gallbladder fossa, but in addition to the gallbladder fossa, they separate the right lobe from the left lobe, and these are located between the interior segment of the right lobe and the medial segment of the left lobe. The left hepatic vein running through the left intersegmental fissure associated with the ligamentum teres and the falciform ligament separate the lateral segment of the left lobe from the left medial segment of the left lobe. So it separates the left lobe into a medial and lateral segment. The three structures located within the porta hepatis are the main portal vein, the common bile duct, and the hepatic artery. The common hepatic artery carries oxygenated blood to the liver, direct from the abdominal aorta, and the hepatic artery is a branch of the celiac trunk, and it is one of the first main branches of the abdominal aorta. So typically the hepatic artery takes a course anterior to the main portal vein in the portal hepatis, and when we gain a longitudinally oriented image, the artery is noted anterior to the main portal vein and posterior to the common bile duct. We describe this as the Mickey Mouse sign, and it is done in a transverse image of the porta hepatis. And in some people, the relationship of the artery and the bile duct is reversed. Two readily identifiable ligaments in the liver are the ligamentum venosum and the falciform ligament. So in utero, the umbilical vein supplies the fetus with oxygenated blood, and the umbilical vein travels to the liver, and this umbilical vein bifurcates into a left and right branch. The right branch of the umbilical vein is what we refer to as the ductus venosus, and the ductus venosus shunts blood directly into the fetal inferior vena cava, and shortly after birth the ductus venosus collapses and becomes the ligamentum venosum. And so the ligamentum venosum is the remnant of the right branch of the umbilical vein, which in utero is referred to as the ductus venosus. The left umbilical vein connects directly to the left portal vein, and after birth it becomes a fibrous cord that we refer to as the ligamentum teres. or the round ligaments. And the ligamentum teres ascends along the falciform ligament, and in cases of recanalization, we attribute those cases to portal hypertension. So just to reiterate, the common umbilical vein in utero enters the liver and branches off into a left and a right. The left umbilical vein connects directly to the left portal vein, and its afterbirth remnant is referred to as the ligamentum teres, or the round ligament. The right branch of the umbilical vein is referred to as the ductus venosus in utero, and it shunts blood directly into the fetal inferior vena cava, and its afterbirth remnant is known as the ligamentum venosum. So sonographically, these ligaments appear hyperechoic due to the amount of fat located within and around them. The ligamentum venosum, which appears as a hyperechoic linear structure, can be noted anterior to the caudate lobe, and the ligamentum venosum is located between the caudate lobe and the left hepatic lobe. The falciform ligament can be appreciated near the left portal vein in most persons, and we see it in the transverse scan, and it often appears as a hyperechoic triangular-shaped structure between the left and right hepatic lobes. And it is important to note that some texts may refer to the area of the falciform ligament as the ligamentum teres, and thus it is vital to understand that the ligamentum teres is potentially identifiable with the lower margins of the falciform ligament. The main lobar fissure, which houses the middle hepatic vein, is seen in a sagittal but oblique plane, and we see it as a hyperechoic line which connects to the neck of the gallbladder, and it arises from the right portal vein. And the main lobar fissure, once again, is used to separate the right and left hepatic lobes. Diaphragmatic slips may present as pseudomasses, and they typically occur in older patients. And they're caused by hypertrophied diaphragmatic muscle bundles, and these appear as hyperechoic strands extending from the diaphragm in the sagittal plane, and they can be confused for hyperechoic masses. So we can go over these useful landmarks that I've just been talking about. As you can see on an anterior view, this is a diaphragmatic surface. We can see the right lobe, the apex of the liver, the left triangular ligament, the coronary ligament, the left lobe. Here's your falciform ligament, and there you go. The ligamentum teres is seen as being one of the inferior connections to the falciform. We have the gallbladder. Gallbladder fossa is posterior to this, and we have the inferior border of the liver. So we can go to a superior view. This is from the diaphragm, what faces the diaphragm. So this is the right diaphragmatic dome. Come here to the superior view. We have the falciform ligament. There's a coronary ligament, there it is, the right lobe of the liver, the opening of the hepatic veins, the right triangular ligament, the ligament that houses the IVC, the bay area, the IVC itself, the caudate lobe, the left triangular ligament, the coronary artery, the bay area, which is it's a continuation here, the left lobe, and there you go, the falciform ligament. We can also view the liver from the bottom, looking up, and we can see the right subphrenic space, And we have the falciform ligament, the left subphrenic space, the left triangular ligament, the lesser omentum, the porta hepatis, the round ligament of the liver, the gallbladder, the posterior layer of the coronary ligament, the right triangular ligament, the IVC hepatic veins, and the anterior layer of the coronary ligament. We can look at it from the back, looking down. So we have a chordate process, the IVC, the ligamentum venosum, the round ligament, and the porta hepatis, in which we see the portal vein, hepatic artery, and bile duct passing through. And there's our gallbladder. So on this slide here, we have the portal venous system. And I had described the portal confluence and what it's formed of. And it is formed of a union of the splenic vein, the inferior mesenteric vein, and the superior mesenteric vein, as they join up here at a region posterior to the pancreas to form the main portal vein. The main portal vein courses into the porta hepatis, and it then splits to become a right portal vein, or the right branch of the portal vein, and the left branch of the portal vein. The hepatic veins are branches of the inferior vena cava. As you can see, there's the IVC behind there. And they take a different course, not necessarily coursing superiorly like your portal vein branches. They course more laterally. And so you have a left hepatic vein, a middle hepatic vein, and a right hepatic vein. And, the IVC splits into the right common iliac vein and the left common iliac vein. So, what do the portal veins look like? So in this image here, we have a number of blood vessels. We can see the inferior vena cava in short axis, and we can see the aorta in short axis, and we can see the portal veins in long axis, identified by their echogenic walls, and the echogenic probably due to an increase in collagen or fat in its walls. So this is what would happen if you get the IVC and the aorta in short axis. You will get the portal vein in long axis. And I believe the reverse is true. So over here we have a Doppler image of flow. Specific flow we're looking at is hepatopetal flow, meaning flow towards the liver. Unfortunately, this image is not colorized, but on this image here we have normal hepatopetal flow within the main portal vein, and there's some respiratory variation. So, we have a sonograph of the hepatic vein, and these veins are quite engorged. And so that is probably indicative of some kind of how would I say, hypertensive process, but I'm not so sure what the conclusion was in this case. But here we have the left hepatic vein. We have the middle hepatic vein over there. It's very important to identify the middle hepatic vein. And then you can identify the left hepatic vein and the right hepatic vein, and they're noted in this image. So our left hepatic vein can be used to separate the left lateral segment of the liver from the left medial segment of the liver. Our right hepatic vein can be used to separate the right anterior segment from the right posterior segment of the liver. And we talked about this previously, but just to reiterate, these hepatic veins can be used to separate the liver into four sort of quadrants. So the right hepatic vein would split the right lobe into an anterior and posterior segment. The left hepatic vein would split the left lobe into a lateral and medial segment, with the middle hepatic vein splitting the right and the left lobes. So we move on to a sonograph of the Doppler signal of the right hepatic vein. So this is a normal signal of the right hepatic vein, as you can see, demonstrating a hepatopetal flow. And here we have a monophasic waveform of the hepatic artery. Here's your monophasic waveform. Here are your peaks. And here's probably your end diastolic volume, I presume. And this is peak systolic velocity. So we can find the portal triad on a sonogram, and it would show up with your portal vein being the largest in profile, with your common bile duct being anterior to your portal vein, there you are, and the hepatic artery being anterior to the portal vein, but still posterior to the common bile duct. So we have our portal vein there, you have your common bile duct there, and you have your hepatic artery there. And note in some patients this relationship between the common bile duct and the hepatic artery can be reversed. This is a better image of what we call the Mickey Mouse sign. And this is a transverse image of the porta hepatis, and the face of Mickey Mouse is shown as the portal vein, and so this is the face. And the ears here are formed from the common bile duct and the hepatic artery. So how do we find the caudate lobe? Well, the caudate lobe, here we are, that is it. The caudate lobe is located between the ligamentum venosum and the inferior vena cava. So this is our inferior vena cava, and here's our caudate lobe, and it is also within the we had referred to this as the caudate, we refer to this as the ligamentum venosum. No, here is our ligamentum venosum. That is the ligamentum venosum, and this is the IVC, that hyperechoic line over there. That is the ligamentum venosum, and here's our caudate lobe, and here's our inferior vena cava. So the inferior vena cava terminates at the heart's right atrium over there, and the carved arrow indicates the right hepatic vein as it branches to enter the liver. So we can also get a sonogram with a falciform ligament, and we can see it in sagittal as well as transverse. In the sagittal image, right here, we can see the the falciform ligament between these arrows here. And in our image in B, we can see the falciform ligament between your medial segment of the left lobe and the lateral segment of the left lobe. So this is a sonogram of the left and right liver lobes, and so this is a sagittal oblique image of the liver demonstrating our right lobe and our left lobe. Now the right kidney is shown here, and we can see the main lobar fissure. There it is. There's our main lobar fissure over there. Our right portal vein, as we said, the main lobar fissure can be seen sort of emanating from the right portal vein and connecting it to the gallbladder. So there you are, there's the main lobar fissure. And in that runs your middle hepatic vein. We can also see the gallbladder filled with anechoic bile. So we can have certain anatomical variants of the liver. And we can have a rhydal lobe, and it is described as a tongue-like extension of the right hepatic lobe. That is most commonly seen in women, and it may extend inferiorly as far as the iliac crest. And it is important to differentiate the rhydal lobe from hepatomegaly. And one could examine the left lobe for any coexisting enlargement. An additional variant to the liver is a papillary process of the caudate lobe, and it is an inferior extension of the caudate lobe, and it can resemble a mass. We can have other abnormalities such as situs inversus or agenesis of a lobe. We can have a beaver tail or ectopic liver tissue. So what are some medications for liver sonography? Well, first and foremost, we should start with preparing the patient, and so the patient should fast for a period of about 8 hours if we're going to examine the entire right upper quadrant. Although departmentally it might vary, some departments require only 4 hours of fasting. Some may not even require any special patient preparation. So the normal liver is homogeneous, and its echogenicity is either equal or slightly greater than the parenchyma of the normal right kidney. That is to say, the liver is either isoechoic or slightly hyperechoic to the normal right kidney. The normal liver is slightly less echogenic than the normal spleen. And in addition, when we compare this with the pancreas, the liver is slightly less echogenic than the pancreas in adults. So the liver measures approximately 13 to 15 centimeters in an adult, and we're measuring this as a sort of mid-clavicular length measurement. And although many authors differ, hepatomegaly is often suspected if the liver measures greater than 15.5 centimeters in the mid-hepatic line. A measurement of the right lobe can be obtained from the uppermost right hemidiaphragm, so you'll see it when you're scanning, to the inferior tip of the right lobe, so something like this. So you can use a horizontal plane, and it is parallel to the anterior level wall through the mid-axillary line. So these are certain indirect signs of hepatomegaly, an extension of the right lobe beyond the lower pole of the right kidney, without evidence of a rider lobe. That is very important. We had said the rider lobe can extend all the way to the iliac crests. Rounding of the inferior tip of the right lobe. So usually the right lobe is sort of triangular, and if it rounds, we can assume there is some hepatomegaly. Extension of the left lobe well into the left upper quadrant. Right, so here we have a pathology. We have fatty liver disease, and we also refer to this as hepatic steatosis, and it is a disorder characterized by fatty deposits within the hepatocytes. We can classify hepatic steatosis as either non-alcoholic or alcoholic. Non-alcoholic fatty liver disease has been cited as the most common cause of chronic liver disease, and in general, non-alcoholic fatty liver disease is both acquired and reversible. And the causes of non-alcoholic fatty liver disease include starvation, obesity, chemotherapy, diabetes mellitus, hyperlipidemia, pregnancy, or glycogen storage disease type 1. We can also have severe hepatitis that can lead to non-alcoholic fatty liver disease. You can have cystic fibrosis or intestinal bypass surgery, or even in the case of use of certain corticosteroids. Fatty liver disease is the hepatic manifestation of a metabolic syndrome that can lead to steatohepatitis. And steatohepatitis, whether alcoholic or non-alcoholic, is inflammation of the liver that has been shown to be a precursor for chronic liver disease, leading to fibrosis, or cirrhosis, or hepatocellular carcinoma. So although a fatty liver is typically asymptomatic, patients may present clinically with elevated liver function tests, AST, ALP. The fatty liver can be described as mild, moderate, or severe based on its sonographic visualization, and the criteria we use is visualization of the hepatic vasculature as well as the diaphragm. Fatty changes within the liver can be diffuse or local, and diffuse infiltration will cause the liver to appear diffusely echogenic, and it will be more difficult to penetrate. So frequently in the presence of diffuse infiltration, the walls of hepatic vasculature and the diaphragm will not be easily imaged. An example is there. So in these two images here, we have image 1 being a diffusely fatty liver, and we cannot clearly visualize the diaphragm, nor can we visualize hepatic vasculature. Whereas in the other case, this is a liver demonstrating focal fatty infiltration. You can still visualize the kidney over there, and you can visualize the diaphragm. The kidney is quite obscured here. So, fatty liver disease. So here I have fatty liver sparing, and it is noted in the sagittal image of the liver. adjacent to the gallbladder, we can see a sparing of a fatty liver. So sonographically, the liver segment affected by focal fatty infiltration will appear as an area of increased echogenicity and can thus appear much like a solid hyperechoic mass. There you go, solid hyperechoic mass. Alternatively, focal fatty sparing of the liver can occur with diffuse infiltration, and both focal fatty infiltration and focal fatty sparing can occur in the same places, and it's much more likely that the signs of sparing and infiltration are seen adjacent to the gallbladder near the porta hepatis. Although both of these may mimic solid masses, they will not produce any mass effect. As you can see, the gallbladder is quite distended, there's no mass effect pressing on its walls, and there's no distortion on its anatomy. So there's some clinical findings for fatty liver disease. So I will just zoom in here. So, clinical findings, we can be asymptomatic. We can find alcohol abuse with the clinical history. They can be chemotherapy, they can be diabetes mellitus, elevated liver function, AST, ALT, hyperlipidemia, obesity, and pregnancy. And the sonographic findings would be a diffusely echogenic liver, with increased attenuation of the sound beam and walls of hepatic vasculature, and diaphragm will not be easily imaged. If there's focal fatty infiltration, there's a hypoechoic area adjacent to the gallbladder near the porta hepatis, or part of the lobe may appear echogenic. Focal fatty sparing, a hypoechoic area adjacent to the gallbladder near the portal hepatis, or part of the lobe or entire lobe may be spared. So this is very important to remember. Focal fatty infiltration presents as hypoechoic areas that may be adjacent to the gallbladder near the porta hepatis, or part of the lobe may appear echogenic. Whereas in sparing, it is hypoechoic areas adjacent to the gallbladder near the porta hepatis, or part of the lobe or entire lobe may be spared, and it can mimic pericholecystic fluid when it is identified adjacent to the gallbladder. So this is the starry sky sign that we had talked about earlier, and hepatitis is inflammation of the liver, and it can ultimately lead to cirrhosis, portal hypertension, and hepatocellular carcinoma. Hepatitis can be acute or chronic, and acute hepatitis is said to resolve within 4 months, whereas chronic persists beyond 6 months. Hepatitis comes in a number of forms. You can have A, B, C, D, E, or G, but the two most common are hepatitis A and hepatitis B. Hepatitis A is spread by the fecal-oral route in contaminated water or in contaminated food. And hepatitis B is spread by contact with contaminated body fluids, inadvertent blood contact, mother to infant transmission, or in the case of intravenous drug abuse. Hepatitis C is also spread by contact with blood and body fluids, and hepatitis C is a leading indication for liver transplantation in the US. Although a new drug exists, and the name of this drug is sofosbuvir, which is potentially curative for hepatitis C. Hepatitis may also be triggered by hepatitis can also be triggered by certain systemic viruses such as herpes simplex or Epstein-Barr. And chronic hepatitis in this case can be caused by Wilson's disease, and both Wilson's disease and hemochromatosis are inherited conditions. Wilson disease causes the body to accumulate excess copper, whereas hemochromatosis is characterized by disproportionate absorption of dietary iron. So hepatitis is often a clinical diagnosis, and patients with any form of hepatitis can experience fever, chills, nausea, vomiting, fatigue, hepatosplenomegaly, dark urine, or jaundice. And so we talked about elevation in liver tests, aspartate aminotransferase, AST, lactate dehydrogenase, LDH, serum bilirubin, or alanine aminotransferase. Impaired liver function as a result of hepatitis may lead to hepatic encephalopathy, a condition in which the patient becomes confused from secondary exposure of the brain to toxic chemicals that the liver would otherwise remove from the body. So, sonographically, a patient with hepatitis may initially have a completely normal appearing liver. However, with time, hepatomegaly and splenomegaly can be observed. And as the liver enlarges, it tends to become more hypoechoic. And that is quite important. It becomes more hypoechoic as it enlarges. And we begin to see periportal cuffing, although it is not always a specific finding. So with this periportal cuffing, we would see an increase in the echogenicity of the walls of the portal triads, and it will sonographically manifest as the starry sky sign. And this is what we see here. Although the gallbladder wall may also be thickened in the presence of hepatitis. So note increases in mid-clavicular length beyond 15.5 centimeters, also other indicators of hepatitis. There are certain clinical findings of hepatitis, and these are chills, dark urine, elevated liver function tests, fatigue, fever, hepatosplenomegaly, jaundice, nausea, vomiting, with the sonographic findings being an enlarged hypoechoic liver with periportal cuffing and gallbladder wall thickening. Next we come to liver cirrhosis, and this is defined as hepatocyte death, or you can have fibrosis or necrosis of the liver. And in the liver cirrhosis, we see the development of regenerating nodules. And a common sequelae of cirrhosis includes portal hypertension and the development of varicosities within the abdomen, as well as portal vein thrombosis, splenomegaly, and hepatocellular carcinoma. The most common cause of liver cirrhosis is alcoholism. But cirrhosis can also be caused by Wilson's disease. In cases of biliary cirrhosis, hepatitis, cholangitis, and hemochromatosis. So patients may have normal laboratory findings until liver cirrhosis extends into end-stage liver disease. But whenever laboratory abnormalities are evident, That would include elevations in AST, LDH, ALT, and bilirubin. Patients may also present with jaundice, fatigue, weight loss, diarrhea, initial hepatomegaly, and ascites. So it's quite important to remember a possible pathway of disease, that is chronic alcoholism can lead to hepatic steatosis, which is a fatty liver, which is reversible. But hepatic steatosis can further progress to steatohepatitis, which can then progress to cirrhosis, then will progress to portal hypertension, then will progress to portal vein thrombosis, and then potentially hepatocellular carcinoma, and at that point it is no longer reversible. So sonographic findings of cirrhosis include an echogenic small right lobe, an enlarged caudate lobe, you can see an enlarged caudate lobe here, and an enlarged left lobe of the liver. The nodular surface, this nodular surface, appears with irregularity and coarse echotexture ascites. There is ascites. There can also be some splenomegaly and cirrhosis caused by alcoholism will lead to the development of nodules that will measure less than 1 centimeter, and we call these micronodular. Although you can have macronodular cirrhosis, which would be caused by hepatitis, and these larger nodules would measure between 1 and 5 centimeters. So larger nodules may be readily seen when ascites surrounds the liver, and if ascites is not present, then a high-frequency linear transducer can be used to analyze the liver surface for any evidence of these surface nodularities. And we can also perform elastography to evaluate the stiffness of the liver. So the stiffness of the liver correlates with cirrhosis complication, including variceal hemorrhage, ascites, and hepatocellular carcinoma. And these are all signs of advanced cirrhosis. Now there's some possible Doppler findings. Now you can have a monophasic flow within the hepatic veins and hepatofugal flow within the portal veins. And these are both findings consistent with advanced cirrhosis and portal hypertension. So here we have 2 images of liver cirrhosis. One is liver cirrhosis with ascites that is noted surrounding the liver, and note the liver margin is irregular and it is partly nodular over there. In addition to this, there is enlargement of the caudate lobe and the left lobe of the liver, which is consistent with liver cirrhosis. There are certain clinical findings. We had talked about these, so we can move on to sonographic findings. There's hepatosplenomegaly initially, then there's a shrunken echogenic right lobe of the liver, which we just saw here. It has these irregular nodular margins. An enlarged caudate and left lobe, there you are. Nodular surface irregularity, coarse echotexture, splenomegaly, ascites, monophasic flow within the hepatic vein, then hepatofugal flow within the portal veins. Next we come to portal hypertension, and this is quite simply the elevation of blood pressure within the portal venous system. The pressure within the portal vein can be altered by quite a number of abnormalities, and the most common is cirrhosis, although it can result from portal vein thrombosis, hepatic vein thrombosis, or IVC thrombosis, or compression of the portal veins by a tumor. Recall that normal flow towards the liver within the portal vein is termed hepatopetal. With cirrhosis, the liver becomes fibrotic or scarred, and it becomes more difficult to perfuse. Consequently, with this resistance to blood flow, blood traveling into the liver via the main portal vein meets greater vascular resistance, and the pressure within the portal veins increases, resulting in portal hypertension. The hepatic artery, which also brings blood into the liver, has to increase its supply as well, and it will consequently enlarge. So the flow within the portal vein can eventually become reversed, and we term this hepatofugal. And we may begin to see certain portosystemic collaterals develop, and certain varicosities as a result of the body's attempt to compensate by channeling blood away from the damaged liver. So certain examples of portosystemic collaterals would include coronary vein, a short gastric vein, a gastrorenal pathway, a splenorenal pathway, an umbilical vein, an anterior abdominal wall vein, or a superior mesenteric vein. These are all collaterals. And one of the most identifiable in this case is the recanalization of the paraumbilical vein, and we term this a patent paraumbilical vein, and it is associated with the left portal vein, the ligamentum teres, and the falciform ligament, and this becomes open again, as it once was in utero, and shunts blood away from the liver into the inferior gastric veins, or inferior epigastric veins, or in this case the superior epigastric veins, and at this point we call it the Cruvillea-Bogue-Martin syndrome. So this is an example of a patent or a recanalized paraumbilical vein, and it extends from the left lobe of this patient who is suffering from cirrhosis and portal hypertension. So this would be a color Doppler image, and it shows the paraumbilical vein being recanalized and extending from the left portal vein, there you are, left portal vein, towards the anterior abdominal wall in this patient with portal hypertension. Portal hypertension varices, so abdominal varicosities may be noted near the splenic hilum or the renal hilum, or at the gastroesophageal junction. Furthermore, sonographic evidence of enlargement and reversed flow within the coronary vein may be seen with portal hypertension. So in some individuals, a normal coronary vein can be seen arising from the splenic vein, and this would extend superiorly to the left. So with portal hypertension, the coronary vein will demonstrate abnormal flow towards the esophagus, and it will measure a diameter greater than 6 millimeters. So unfortunately, the shunting of blood towards the esophagus increases the risk for esophageal hemorrhage and death. Enlargement of the portal vein with portal hypertension is quite apparent, and it comes prior to development of these collaterals. And we had said the collaterals are the coronary vein, the short gastric vein, the gastrorenal pathway, splenorenal pathway, umbilical vein, the anterior abdominal wall, and the superior mesenteric vein. So, along with hepatofugal flow, the portal vein diameter exceeds 13 millimeters in the AP dimension, and the superior mesenteric vein will exceed 10 millimeters. And this all increases the patient's likelihood of developing portal vein thrombosis. So essentially, patients with portal hypertension will have many of the same sonographic findings as cirrhosis, including ascites and splenomegaly, with the addition of a portal vascular and shunting kind of abnormality with this development of collateral channels. So hematomesis may be present, and it's an ominous sign of a ruptured esophageal varus, and it markedly increases mortality. Other clinical findings of portal hypertension include hepatic encephalopathy, and we talked about that previously, this confusion associated with the liver's inability to filter out toxic substances from the blood. We can have dilation of the superficial veins of the abdomen, and we term this caput medusa. The patient might also come with tremors. So one of the treatments for this is shunts placed surgically to reduce the likelihood of complications. And we can have a portal caval shunt, a splenorenal shunt, and a mesocaval shunt. A common minimally invasive interventional treatment for portal hypertension is by means of a transjugular intrahepatic portosystemic shunt. And it is a temporary treatment, but it improves the condition of the patient, and it involves placement of a stent between the portal veins and the hepatic veins to shunt blood and reduce portal systemic pressure. So the transjugular intrahepatic portosystemic shunt is often evaluated with Doppler for patency. And a patient in this case here with portal hypertension is seen with splenic varices, and these are noted adjacent to the spleen in the area near the splenic hilum. That is the spleen over there. We can have an enlarged coronary vein, and this is seen posterior to the left lobe in a patient with portal hypertension. So the clinical findings, we've gone over that for portal hypertension, and we can list the sonographic findings. Hepatomegaly initially, a shrunken right lobe, an enlarged caudate lobe, nodular surface irregularity, a coarse echo texture, splenomegaly, ascites, monophasic flow in the hepatic veins, hepatofugal flow within the portal veins, enlargement of the portal vein, enlargement of the superior mesenteric vein, enlargement and reversed flow within the coronary vein, enlarged hepatic arteries, abdominal varicosities at the splenic hilum or the rhenic hilum, and a patent paraumbilical vein. Portal vein compression and portal vein thrombosis. Portal vein compression leads to portal vein obstruction, and it is a common occurrence or indicator of tumors from adjacent organs or in any lymphadenopathy. Portal vein thrombosis is the development of a clot within the portal vein. And portal vein thrombosis is seen in conditions such as hepatocellular carcinoma and portal hypertension. The thrombus can completely occlude the portal vein, and in this case the development of collaterals within the portal vein region will occur. And these collaterals are small vessels that try to shunt blood around the clot, and it results in a mesh of tiny vessels surrounding this area, and we term this a cavernous transformation. In addition to this, as the disease progresses, larger collaterals can develop, and these patients may complain of abdominal pain, low-grade fever, leukocytosis, hypovolemia, and they will present with elevated liver function tests. Initial sonographic evaluation may show thrombus, but at times this thrombus can be isoechoic to the surrounding circulating blood. But with time, thrombus in the portal vein will become more echogenic and more noticeable, and this cavernous transformation will appear as a worm-like serpingeous kind of presentation within the region of the portal vein, and the portal occlusion can also be the result of tumor invasion within this portal vein. Portal vein thrombosis compromises hepatic blood flow, and we evaluate it primarily through color Doppler. Clinical findings include abdominal pain, elevated liver function tests, hypovolemia, leukocytosis, a low-grade fever, nausea and vomiting. Sonographic findings include an echogenic thrombus within the portal vein, or a cavernous transformation of the portal veins, which can be worm-like or serpiginous within the region. Portal venous gas. So you can have gas within the portal veins or mesenteric veins. That results from ischemic bowel disease, and it is typically fatal. However, portal venous gas may be associated with diverticulitis, sometimes appendicitis, inflammatory bowel disease, bowel obstructions, or ulcers. The sonographic findings of portal venous gas are consistent with the evidence of small, bright reflectors noted within circulating blood inside the portal vein, and larger air collections may produce a ring-down artifact, and we talked about the ring-down artifact in the previous lecture. Care should be taken not to confuse portal venous gas with pneumobilia, and pneumobilia is air within the biliary tract. So there are certain clinical findings of portal venous gas. They can be a recent bout of diverticulitis, appendicitis, or inflammatory bowel disease. They can be ulcers within the bowel, a GIT cancer, or an invasive procedure involving stent placement, or an endoscopic analysis of the bowel. Sonographic findings include small, bright reflectors noted within the circulating blood inside the portal vein, and large air collections may produce a ring-down artifact. So we have here a cavernous transformation of the portal vein, representing portal venous thrombosis or portal vein thrombosis, and a transverse image through the portal hepatis demonstrates multiple small collateral vessels in the area of the portal vein. There you are. Collaterals representing a portal vein thrombosis. Budd-Chiari syndrome. This is the occlusion of the hepatic veins, and there can be coexisting occlusion of the IVC. Remember, the hepatic veins are direct branches of the inferior vena cava. Budd-Chiari syndrome can be seen secondary to a congenital webbing disorder or a coagulation abnormality. They can be as a result of tumor invasion, thrombosis, oral contraceptive use, pregnancy, and trauma. Clinical symptoms of Budd-Chiari when found in female patients on oral contraception include ascites, right upper quadrant pain, hepatomegaly, and splenomegaly. Other patients may suffer from extensive upper abdominal pain and elevated liver function tests. Sonographic findings include the non-visualization or reduced visualization of hepatic veins, and thrombus may be noted within the hepatic veins. The caudate lobe may be enlarged, and calodopa will often yield evidence of absent flow within the hepatic veins. The IVC may also be narrowed. So clinical findings include ascites, hepatomegaly, splenomegaly, and upper abdominal pain. Sonographic findings include non-visualization or reduced visualization of the hepatic veins. You can have thrombus within the hepatic veins, you can have an enlarged caudate lobe, a lack of flow within the hepatic veins, or narrowing of the IVC. Next we come to focal liver diseases, and in this case we're looking at hepatic cysts. So true hepatic cysts are not encountered until middle age, and these hepatic cysts are often associated with autosomal dominant polycystic kidney disease. Clinically, hepatic cysts associated with ADPKD are often asymptomatic, and they do not alter liver function tests. They may be multiple, and they may not always conform to sonographic appearances of simple cysts, and their shape can be somewhat irregular. Clusters of cysts with jagged walls may be noted, and these may produce a complex appearance. However, all other simple cysts, or rather all other simple cyst criteria should be present. So these clusters of cysts would have smooth walls and presence of through transmission, and they should be entirely anechoic. Complex hepatic cysts are often due to hemorrhage and may have internal echoes, thick walls, or calcification of some simple solid components. When pain occurs because of hepatic cysts, it may be due to hemorrhage, infection, or secondary to mass effect. Hepatic cysts may also be noted in patients with von Hippel-Lindau disease, and these may be solitary or idiopathic. So hepatic cysts, they can be asymptomatic, or they can be hemorrhagic. They are usually anechoic masses with posterior enhancement, and they may have irregular shapes, or clusters of these cysts may be noted. So we have benign hepatic cysts. These are liver masses with well-defined borders and are completely anechoic. They have thin walls, and they demonstrate posterior enhancement, and there's some edge shadowing as well. Autosomal dominant polycystic kidney disease cysts, and these appear as multiple cysts of the kidney. There you are. Amoebic hepatic abscesses. Amoebic hepatic abscesses come from the parasite Entamoeba histolytica, and they grow in the colon and invade the liver via the portal vein. Entamoeba histolytica is typically transmitted through contaminated water found in places such as Mexico, or Asia, India, and others. And so such patients may have visited these areas. Clinical features include hepatomegaly, right upper quadrant pain, general malaise, or signs of dysentery. And dysentery may be bloody, in this case bloody diarrhea. And laboratory findings may include leukocytosis, an elevated liver function test, and mild anemia. Amoebic hepatic abscesses are typically round, hypoechoic or anechoic. Hypoechoic in that case, anechoic in that case. They contain debris, there you are, that one contains debris, and have some acoustic enhancement. Amoebic abscesses are most often noted within the right lobe of the liver, near Gleason's capsule. They may also be multiple, and they may appear hypoechoic or contain a fluid debris level. Oftentimes, amoebic abscesses are indistinguishable sonographically from a pyogenic liver abscess, and therefore require a serologic confirmation. And these masses are usually treated medically, although aspiration may be performed. Complications include rupture or extension into the chest or peritoneal cavity. So here we have a hydatid cyst, and it's a complex mass containing a detached membrane, which is a typical appearance of a hydatid cyst. This figure here is an amoebic abscess, and it appears as a hypoechoic mass surrounded by a hypoechoic wall. So just on this point of amoebic hepatic masses, sonographically they appear as round hypoechoic or anechoic masses, and they may contain debris and acoustic enhancement. Pyogenic hepatic abscesses, these can result from the spread of infection, from inflammatory conditions such as appendicitis or endocarditis, and the bacteria enter the liver through the portal vein or the hepatic artery, or from an operative procedure. They can also enter via the biliary tree. Clinical symptoms of a pyogenic abscess include fever, leukocytosis, possible abnormal liver function tests, right upper quadrant pain, and hepatomegaly. Pyogenic hepatic abscesses may appear as complex cysts with thick walls. These cysts may contain debris, septations, and/or gas, and the air within the abscess may produce dirty shadowing or a ring-down artifact. So here is an example of a pyogenic liver abscess. There's a hypoechoic mass with rather indistinct borders and some posterior enhancement. Really, I would say it has thick walls as well. So sonographically, pyogenic hepatic abscesses appear as complex cysts with thick walls, and these masses may contain debris, septations, and/or gas, and the air within the abscesses may produce dirty shadowing or ring-down artifact. Next, we have hepatic candidiasis, and this results from the spread of fungus. And the fungus we're looking at here is known as Candida albicans, and it exists in the blood of the liver, and those who are prone to develop hepatic candidiasis are typically immunocompromised. So patients may have right upper quadrant pain, fever, and hepatomegaly, and sonographic findings include multiple hypoechoic masses with hypoechoic borders, and we can describe them as targets or as halos or bull's eye lesions. They're typically 1 centimeter or smaller in size. and all the lesions may calcify. So here is an example of hepatic candidiasis. And the transverse image of the liver demonstrates multiple hypoechoic lesions. Cavernous hemangioma is the most common benign liver tumor. They're most commonly found in women, and they're usually incidentally detected. And the most common location of a cavernous hemangioma is within the right lobe, and they characteristically appear as a small hypoechoic mass measuring less than 3 centimeters. So although hemangiomas are comprised of blood vessels, detectable flow may not be seen on color Doppler. And this is due to the fact that blood flow may be exceedingly slow. And unfortunately, hemangiomas may also appear as hypoechoic or complex, and therefore cannot be sonographically distinguished from metastatic liver disease. So here we have a small hypoechoic mass in the right lobe of the liver. Focal nodular hyperplasia has been cited as the most common benign liver tumor. In this case, it has been cited as the secondly most common benign liver tumor. The most common is a cavernous hemangioma. Once again, it's most incidentally discovered in women, much like the hemangioma, and it's a mass composed of hepatocytes and fibrous tissue. Patients who have it are often asymptomatic, but the mass can impinge on surrounding anatomy, and pain will likely ensue. It may have multiple sonographic appearances. It might be isoechoic or hypoechoic, and it may contain a stellate or star-like scar. The central scar will appear as a hypoechoic or hypoechoic linear structure within the mass, and hypervascularity is identified using color Doppler. And focal nodular hyperplasia has often been referred to as a stealth lesion, because it may be difficult to identify secondary to its slight sonographic disparity from normal liver parenchyma, but it is usually isoechoic, hypoechoic, or hypoechoic, and there's a central scar that can be seen. And it will often reveal hypervascularity with color Doppler. So here we have an echogenic mass within the calipers. Quite hard to see, it's quite stealthy, but there it is. And it is noted in the left lobe, slightly hypoechoic to the liver. And that is focal nodular hyperplasia. Hepatocellular adenoma. And it is a rare benign liver tumor, once again often associated with the use of oral contraceptives. Patients are typically asymptomatic, and there may be multiple adenomas. Sonographically, a hepatocellular adenoma presents as mostly hypoechoic, although it may be hypoechoic or isoechoic or mixed in terms of echogenicity. Clinical findings, usually asymptomatic, associated with oral contraceptive use, and pain occurs with hemorrhage. This is a hepatic adenoma. It's a well-circumscribed mass located in the right lobe of the liver and superior to the right kidney. Hepatic lipomas are rarely encountered, and its sonographic appearance is usually that of a hyperechoic mass. Sonographically, that is it, a hyperechoic mass. Clinically, it is asymptomatic. Hepatic hematoma. This can be the consequence of trauma or surgery, and patients will have a decreased hematocrit. Patients can present with fluid that is under Glisson's capsule, and hematomas can be solid or complex depending on their age. Initial hemorrhages appear echogenic with the development of a clot, and over time it resolves, and it may appear more cystic and complex. Focal hematomas have been known to calcify, and therefore in the acute stage an intrahepatic hematoma may be difficult to visualize. So sonographically, hepatic hematomas, when they're fresh, may appear hyperechoic. Older hemorrhages can appear anechoic or complex, and liver or hepatic hematomas can be intrahepatic or subcapsular. Clinical findings: trauma, recent surgery, pain, and decreased hematocrit. So here's an example of an older hematoma, and it has become sonolucent, and you can see it is quite isoechoic to normal liver tissue. Hepatocellular carcinoma is the most common form of liver cancer, and it is often seen in men. And the clinical findings include elevated alpha-fetoprotein levels, liver cirrhosis, chronic hepatitis, unexplained weight loss, hepatomegaly, fever, a palpable mass, and abdominal swelling. Sonographically, it appears as a solitary hypoechoic mass, or it can be heterogeneous, and there can be multiple masses spread throughout the liver. The hepatocellular carcinoma has a hypoechoic halo and a central echogenic portion, and it typically looks like a bull's eye. There can be possible ascites. In this case, we have a solid hypoechoic mass here that represents a bull's eye. And this is, I could say, hypoechoic, and this was characterized as a hepatocellular carcinoma. Hepatic metastasis, and the liver is a common location for metastatic disease to manifest. So the malignant cells enter through the portal veins or lymphatic channels, and the primary cancers include the gallbladder, colon, the stomach, the pancreas, the mammary, and the lung. So patients may present clinically with abnormal liver function tests, weight loss, jaundice, right upper quadrant pain, hepatomegaly, and abnormal swelling. Sonographically, we can see hyperechoic or hypoechoic or even calcified or any kind of heterogeneous mass, and the masses demonstrate a hypoechoic rim and a central echogenic region, and this possible ascites. So here we have metastatic liver disease, and these originated in the patient's rectum, and we also have metastatic liver disease here, and this case is a neuroblastoma. Next we come to liver Doppler. This is a Doppler assessment of the liver, and normal flow within the portal veins should be hepatopetal, continuous, monophasic, and have low velocity around 20 to 40 centimeters per second. Flow assessment should be obtained at the end of respiration, and this is because deep inspiration may blunt or make the hepatic vein lose its pulsicity or pulsatility. The hepatic artery should demonstrate a continuous low resistance waveform with a quick upstroke and gradual deceleration with diastole. So next we have TIPS evaluation, and the TIPS is a transjugular intraportal systemic stent, and it may be inserted via the jugular vein and ultimately placed between a hepatic vein and a intrahepatic portion of the portal vein. Most often the shunt is created between the right portal vein and the right hepatic vein, and it is left in place. So we study this using Doppler, and here we are. And this is an example of TIPS failure. The occluded TIPS lacks color flow filling. Next we come to liver transplant assessment. Since hepatitis C is the most common disease requiring a liver transplant, in certain cases the liver might be removed and replaced with the liver from a donor. So the liver from the donor is attached to the native portal vein and the hepatic artery. And we have a piggyback that is created, a piggyback attachment made between the donor and the recipient IVC. So with sonography, a liver transplant should appear similar to a normal native liver. All vasculature should be evaluated. Although at times with acute rejection, the liver appears normal. And suspicion should arise when the liver appears diffusely heterogeneous. So in liver transplants, hepatic artery thrombosis is the most common vascular complication. Next, we can look for other complications, including biliary strictures, cholangitis, sludge, or stones. So this is what they mean when they say a piggyback attachment is made between the donor and the recipient inferior vena cava. So this is the donor liver, and this is the donor portal vein, the hepatic artery, and the common bile duct. And they have all been attached to the recipient's bile duct, portal vein, and hepatic artery, as well as to the IVC. So we have a pediatric liver pathology, which is a hemangioendothelioma, and so it's infertile, and it's the most common benign childhood liver tumor. They're typically identified in the first few weeks or months of life. Clinical findings include hepatomegaly or hemangiomas of the skin. And sonographically, they appear as homogeneous or complex hepatic masses, and they may contain calcifications or cystic spaces. And in this case, this patient presented with hepatic artery thrombosis. And power Doppler reveals flow in the main portal vein, but no detectable flow within the hepatic artery, yielding a diagnosis of hepatic artery thrombosis. Next we have hepatoblastomas. These are malignant pediatric tumors, and they're the most common malignant tumors of childhood. They are symptomatic, but the patients have palpable abdominal masses, hepatomegaly, abdominal pain, weight loss, anorexia, and jaundice, as well as elevated alpha-fetoprotein levels. Sonographically, findings of hepatoblastomas are solid, hyperechoic heterogeneous masses, and the masses may contain some calcifications. And so that is the end of this portion of abdominal sonography.